Good morning, everyone. My name is Rachel Carter. I am a clinical pharmacist at Primary Plus. Primary Plus is a group of federally qualified health centers. We serve rural Eastern Kentucky and Southeastern Ohio. I just want to say what I'm presenting on today is my research project that I did during my pharmacy residency. I completed my pharmacy residency with the University of Kentucky College of Pharmacy. It was a wonderful experience. I just finished up residency this past June, and I am now adjunct faculty at the UK College of Pharmacy, so I get to teach 1 day a week and still practice. I think you will find this presentation useful. Hopefully you can take something from this presentation and apply it to your own practice or your own clinics. I just want to say that this presentation is focused mainly on RPM remote patient monitoring. What a great presentation on CCM before mine. So I won't spend as much time talking about that service, but I do want to preface this by saying at Primary Plus, our RPM and CCM services are pharmacist-led. Most of what we do is pharmacist-led. We currently have 4 clinical pharmacists, hoping to get 5 or 6 here soon. That is a little bit about me and my practice site. So this presentation is titled ECO ROADS, which stands for Enhancing COPD Outcomes, RPM, Pulse Oximetry, and Direct Billable Clinical Services. Here is some background about my residency research project. COPD is one of the top 3 causes of death worldwide. I am from Eastern Kentucky. My husband's from Eastern Kentucky. I love this state and the patient population I get to serve. This is home. And a lot of Kentucky residents still smoke. Approximately 20% of Kentucky residents still smoke, and that is the main risk factor for COPD. As you can imagine, the prevalence rate of COPD is greater in Kentucky than most states. It's actually one of the top 11 with the highest prevalence rate. And peripheral oxygen saturation, or SpO2 monitoring, is a fundamental component of long-term COPD management. Remote patient monitoring is the use of devices with biometric sensors such as pulse oximeters to monitor patients outside of the traditional care setting. We have wonderful vendors here talking about RPM devices, so I do want to say Primary Plus has an established RPM program. Before I started this research project, we were currently offering RPM for hypertension, diabetes, and heart failure. Hypertension and diabetes were our main disease states we were focused on. We knew we had access to pulse oximeters, but we weren't in that space yet. We weren't really using them. So when I started this initiative, there was currently no pharmacist-led remote patient monitoring specifically focused on COPD in Eastern Kentucky, which was a driving force for me to do this project, and that's where prevalence rates and smoking rates are the highest. The objectives of my research project were to determine the exacerbation rate of COPD in patients after enrollment in a pharmacist-led RPM program that utilized a Bluetooth pulse oximeter to measure SpO2. And then secondary objectives were to assess the impact of pharmacist-led RPM for COPD on adherence with maintenance inhaler therapy, smoking cessation, immunization uptake, and patient satisfaction. I want to tell you all about my patient demographics before I get into how I designed this research project. The median age of enrollment for my patients was 68 years old. My youngest patient was 52 and my oldest patient was 82. I had 8 male patients enrolled and 6 female patients enrolled. 13 of my patients identified as Caucasian and 1 identified as African American, and 7 patients were smokers at baseline. There was variability in primary care provider credentials. The main thing I want to highlight from this slide is that 9 patients were referred to my program by a physician's assistant, and only 1 was referred by an APRN, which is interesting. The primary care clinic that was my practice site during residency and where I'm currently employed at now has a mix of primary care providers. We have 1 MD, 2 DOs, several APRNs, and several PAs there. This is a diagram about how I set up this research project. So I went through my methods before I even launched this and thought, how am I going to do this and make it most efficient for myself, for the providers in our clinic, and my patients? We chose to keep our traditional RPM referral process that we were currently using for hypertension and diabetes and heart failure. We just expanded it to COPD. So these providers got an info session on my project, what I was trying to do, and they placed a referral to me for any patient that had a diagnosis of COPD in their chart, so they had that J44.9 diagnosis code. Another factor that they could have looked at is if a patient had PFTs in their chart. That was also an indicator that maybe they should be referred to this service. Then patients met with myself. I was the primary investigator. I was the only point of contact for those patients. Piggybacking off of one of your points, I was the only one contacting these patients every month. We built established relationships. So they met with me to do a pre-intervention survey before I gave them the pulse oximeter. And I just asked them a couple questions. How confident are you talking to your pharmacist about COPD? How confident are you getting vaccines that your pharmacist recommends? Are you currently satisfied with your COPD treatment and education that you've received thus far? Things like that. So they completed that, and then I showed them how to use a Bluetooth pulse oximeter. It seems intuitive, but patients in rural Eastern Kentucky can struggle with technology sometimes and how to use these devices. So that was a big component of our first meeting. And then after that pulse oximeter education and survey was completed, they were asked to take the Bluetooth pulse oximeter home and measure their SpO2 once a day for 90 days. It was a 3-month study period. Most of my patients were compliant with this, which I'll talk about later in the presentation. And I would contact these patients if they had an SpO2 less than 92% or attempt to contact these patients. You may wonder, why did I use 92%? Well, that is generally the ideal SpO2, around 92% for patients with COPD. So if they drop below that, I wanted to get in contact with them, see if they were feeling okay. Maybe they needed to come into clinic. I couldn't always get a hold of them, which I'll talk about in the limitations section a little bit later. But regardless of if their SpO2 dropped below 92% at all during the week, I did a weekly phone call on Fridays with these patients for chronic care management services. How are you doing? What refills do you need? I would recommend this vaccine for you. Are you using your maintenance inhaler properly? And then I would recommend a medication, a vaccine, or any treatment recommendations to their primary care provider in the same clinic I was working in, and the providers would implement those recommendations accordingly, and then the cycle just continued for 3 months. Patients came back to me at the end of 3 months to return their pulse oximeter, or they had the option to remain enrolled in this RPM service because it's still ongoing at Primary Plus and part of my job today, which is awesome that it's continued post-residency. And I do want to mention these patients did receive monetary compensation for completing this program. This slide reviews my results, the average SpO2 reading. So I analyzed data by the initial 45 days of enrollment and the final 45 days of enrollment. So during the initial 45 days, here highlighted in red, there were 4 patients that had an average SpO2 less than 92%. You can see one of them had an average of 86.39, and I'll talk about that patient a little bit later. In the second or final 45 days of my study, only 2 patients had an SpO2 less than 92%. So 2 of them improved above 92% on average, and then overall 7 patients experienced an increase in SpO2 to some extent. So that was roughly half of my patients. The average increase of SpO2 is 0.6. There's more data to know what's clinically significant, statistically significant, because I did have a small sample size. But in summary, patients did experience better SpO2s after enrollment in this pharmacist-led RPM program. And then this results encompasses the satisfaction survey that I gave to these patients pre-enrollment and post-enrollment. So pre-enrollment, there were 2 patients that were either very unsatisfied or unsatisfied with their COPD treatment and education before they met with me as a pharmacist. After enrollment in this program, there were no patients that reported that they were unsatisfied or very unsatisfied, and the number of patients that were very satisfied with education and treatment increased. And I attribute that to those weekly CCM check-in calls and that established relationship that I developed with my patients throughout this process. These are elements of care that my RPM program addressed. I got 1 patient in contact with a pulmonologist. So prior to my study, only 3 had an established relationship with a pulmonologist. Afterwards, I had 4. The biggest change for this program was baseline therapy. I identified baseline therapy as COPD patients that were continuously filling a maintenance inhaler that included a LABA/LAMA or an ICS. For those of you that aren't pharmacists in the room or familiar with that language, that's a long-acting beta agonist, long-acting muscarinic antagonist, or an inhaled corticosteroid. Those are recommended by the GOLD guidelines, the governing body for COPD treatment. So prior to my study, only 9 patients had appropriate baseline therapy, and afterwards 13 did. There was no change in the number of patients that had a maintenance inhaler. But as a result of this program, 8 vaccines were successfully administered by myself as a pharmacist, most notably 3 Tdap vaccines, 2 RSV vaccines, 2 influenza vaccines, and 1 pneumococcal vaccine. And these had been recommended to patients prior to my project. The patients just never followed through. They forgot to stop at the pharmacy and get their vaccine, or they just forgot they were supposed to get it, things like that. So I do also want to mention there was never one vaccine I recommended that a patient said, no, I'm not getting that, or didn't follow through on. And again, I attribute that to weekly CCM check-in calls and that established relationship that I had with them. I want to discuss a little bit about my project at this point. Like I said, an average SpO2 goal for a patient with COPD is around 92%, but a normal SpO2 for a healthy individual is around 95% or higher. So when those patients drop below 92%, I would call them, and throughout the duration of this study period, I had roughly 1,200 SpO2 readings that were sent to our clinical RPM dashboard, and 21% of those fell below 92%. That comes out to roughly 3 exacerbations or more than 3 exacerbations, roughly 20 exacerbations per patient during my study period, and that was not realistic. That was a limitation of my study. COPD patients only experience 2 to 3 exacerbations per year. So again, this is not realistic, but I was conservative calling them when it dropped below less than 92% because we're accountable for these patients administering RPM. If they have a low reading and we don't act, that falls on us as pharmacists. Again, 4 more patients are receiving guideline-recommended COPD therapy, and 8 vaccines were administered, and patient satisfaction with education and treatment improved. But there were several limitations in study design. In addition to my small sample size, there was a high degree of variability in testing. Some of my patients loved these little pulse oximeters and would test 4 or 5 times a day. And then other patients would test every other day or maybe once a week. When they did the enrollment forms, they consented to testing once a day, but life happens. It's hard for our patients to be adherent with their medications and measuring their SpO2 or whatever biometric data they're supposed to measure with our RPM devices. And then SpO2 readings vary greatly based on tissue perfusion, if a patient has nail polish, if their fingers are sweaty, things like that. So this wasn't always reliable. And then my patients didn't answer the phone all the time if I was trying to get in contact with them for a low reading. Cell phone service in Eastern Kentucky is limited. Some of these patients didn't have good cell phone service when they went home, so I couldn't get in contact with them. I want to tell you all a little story that happened during this residency project, and it was the most impactful part of my pharmacy residency by far. I enrolled a patient in this program. She is 54 years old and has end-stage COPD, stage 4 COPD. And I got a reading, and it was 34. For those of you in the room that are familiar with SpO2, that's low. And I was like, there's no way that's truly 34. So I called her because as my, duty as a pharmacist, it was low, RPM were accountable, I had to call her. I could not get a hold of her, and I was very worried about her. I didn't know if she was alive, if that reading was truly accurate. And as a pharmacist, I chose to do a welfare check on her. How many of you in the room have had to do a welfare check on a patient before? Yeah, it's not a great time. So this is the first time I had to do it as a pharmacy resident. So not really confident in my abilities as a pharmacist at that point in time, that early on during residency. And I had to have the police go check on her. So they go to her house, and she was fine. It was an error with the O2 or the pulse oximeter. Again, she does have stage 4 COPD, so it was still pretty low, but it was not that low. She was breathing, she was fine. And she called the clinic very angry with me. And she said, I am so mad that you sent the police to my house to check on me. They showed up unannounced, knocking on my front door. I was very scared and upset, and she was quite angry with me. And I apologized, explained that that's what I had to do. She consented to the program and the research study that was outlined in the parameters, and I just went on about my day. The next day, she called the clinic, and she wanted to talk to me, and she said, thank you, Rachel. Nobody has ever cared about me that much in my entire life. And That is why I love my job as a pharmacist. We make such a difference in these patient lives, and now she's one of my favorite patients and comes in to see me all the time. And now my pharmacy resident has gone to work with her and meet her, so it was a wonderful project and experience, even if there were limitations to the study design. So in conclusion, Kentucky has one of the highest prevalence rates of COPD in the United States, and an established relationship with patients and providers is paramount for implementation of pharmacist recommendations or even services, really. And RPM requires frequent communication to foster those trusting relationships with our patients. However, biometric data should be analyzed comprehensively rather than as isolated values, and enrollment in a pharmacist-led RPM program for COPD does increase average SpO2 at baseline, adherence with guideline-directed therapy, immunization uptake, and patient satisfaction, but more data is needed to determine what change in SpO2 is clinically significant, and a longer study duration is necessary to fully understand the impact of pharmacist involvement on COPD and clinical outcomes.